I'm really privileged today to introduce to you our two speakers. That's online. Both of them are online. So I'm quickly going to share with you a little bit about their background. Both of them are not actuaries by training. They are in the statistical field. So we've got an opportunity to learn from others as well in this process. Shamini she's married to an actuary, so we feel for you, Shamini. So Shamini is an epidemiologist, biostatistician by training. She was trained at the London School of Hygiene and Tropical Medicine and King's College in London. She holds positions in the PHR industry at HBF, so she's also with our team on a part-time basis, and in the medical research team at Telethon Kids Institute as well in Perth. She's also in an advisory role to the British government or English government. Before coming to Australia, she held a role as principal statistical advisor within the Health Intelligence and Public Health in England, where she and her team developed excess mortality estimates. That's what we'll be talking about today. It's used for monitoring and decision making during the COVID pandemic in England, and her work there also involves estimating mortality displacement, which is a conversation we're having today. It's also really a privilege to have Professor Paul Burton on board. He's a professor of data science for health in the Population Health Sciences Institute at Newcastle University in the UK. Over his career, his research has been over three broad themes around methods of research in biostatistics and genetic epidemiology, focusing on GLMs and GLM mixed models. So a deep focus on the statistical and correlation structures there, applied research in genetic epidemiology and complex disease epidemiology. Also with health data science with a focus on the design, setup and harmonization of different biobanks and cohort studies. So it's really a big privilege for us to have people of that stature with us that have seen a number of things. So the focus for us today is we have made this as a health session specifically because there's been a number of focus areas or thoughts around mortality in the industry, and we know that in the UK there's been a lot more cases of COVID and it had a deeper impact in the service delivery. So what we are keen to understand is to understand what is the forward implications for our health system, and specifically from a health funding perspective, how we would estimate what are the expenses that we may see in the future. So we are potentially looking at this method. They have developed this method that look at displacement. I'm not going to try and explain to you how it's going to work. That is what they will be doing today. And then we'll hand over then to Shamini to start us off, and we'll take then questions at the end. Thank you. Shamini.
Just to add that it's Professor Peter Goldblatt that's here today with us. Professor Paul Burton unfortunately couldn't make it. So a quick intro on Professor Peter Goldblatt is that he is a professor at UCL, which is University College London, in the Health Equity Institute, and has had a career with the Office for National Statistics as the head statistician, as well as been involved in a number of major reviews across Europe and England. But you can read his bio in detail, I think, online. And in line with that, obviously Peter and I are presenting on behalf of a wider team, which was within Public Health England, that's now moved into the Office of Health Improvement and Disparities within the Department of Health and Social Care in England. So today we're going to talk to you a little bit about understanding the impact of COVID-19 and how you might adjust health utilisation forecasts, one particular method that we've developed to do so. So to start off with, talking to you about something you already know, which is about forecasting in the private health insurance sector. Forecasting plays a crucial role, as you know, in planning and pricing within PHI. And when you're producing forecasting models, they produce a measure of what is expected in upcoming time periods, and that can be termed the baseline forecast. Now, this is based on historic data, trends within historic data to produce that baseline forecast. And when a disruptive event occurs, such as the COVID-19 pandemic, these baseline forecasts can be used as a measure of what would have been expected had that not occurred. And in statistics, we call that counterfactual analysis. And as you can see on the right-hand side of the screen, you might use previous years of data to estimate what you expect, and then compare. If you use that within that period, you can compare to what you observe within the period and get an overall estimate of excess or impact. However, while these have been used, quite a lot in the past for things like heat waves, when you have a prolonged period of disruption like we've had in the pandemic, these baseline forecasts can become unreliable because the historic trends from which they're constructed are no longer reliable as predictors of future events. So today we're going to do 4 things. We're going to discuss the use of forecasting for surveillance and measuring the impact of a disruptive event, so how you use it in real time. And we're going to describe how we used this counterfactual analysis of mortality to monitor and respond to the COVID-19 pandemic in England. And we're going to describe specific underlying causes of deaths that may be of interest to the private health insurance sector. We'll describe how a prolonged disruptive event, such as a pandemic, can result in displacement of events. In this case, we're looking at mortality, making those baseline estimates unreliable. And we'll present a method for addressing displacement and showcase how we're using this to measure mortality displacement caused by the pandemic in England and adjust the baseline and therefore excess mortality estimates in England. So why is forecasting, or why is your baseline forecast important for surveillance of a disruptive event? Well, in relation to the COVID-19 pandemic, one of the reasons it's been so critical for us is because it's sensitive to both the direct and indirect effects of the pandemic. So if you can see in the chart on the right-hand side, the yellow part of the bar represents a COVID mortality, and grey is other causes or no mention of COVID on the death certificate. The purple line represents the expected estimates of mortality for each week in England based on our forecasts. And in the early part of the pandemic, we did not have adequate testing for COVID-19 available. So you can see how this estimate was used to detect mortality over and above what we would have expected that did not have COVID-19 on the death certificate. So we were able to detect both the direct and indirect effects, misclassification, but also we'd be detecting anything related to service use. So if people weren't going in and using services, we could detect an excess death over and above what we would have expected. So this type of measure is not dependent on detection patterns. It provides information, therefore it provides information for managing and timing, and the timing and extent of the responses in this case, to the pandemic. But it's also been critical for longer term impacts of this disruptive event. And we can look at that from specific areas geographically to population groups, as well as causes of death and places of death. So if you see towards the right-hand side of the chart, in longer term, we do see excess over and above what we would have expected in late July. So while we describe this in relation to the pandemic, this sort of surveillance methodology can be used for climate change events, so floods or fires, but also, say, for example, in PHI, contract negotiation, following a contract negotiation, having a look at the impact of that. And we look at mortality as an outcome, but you could look at utilisation of services, claims, policy uptake, policy churn, for example. So generally, in terms of surveillance of the overall impact, often people look at the cumulative impact of the pandemic, and this is one of the published estimates of the cumulative impact of the COVID-19 pandemic in England. We see about 108 excess deaths over and above what we would have expected. And the chart there shows that over time. But it can also be you can also use it for real-time surveillance, and particularly in the recovery period, as I mentioned in the earlier chart, you can see where we're experiencing excess over and above what we expect that's not related to COVID-19. And today we talk about how we use these charts in the pandemic, but also why we believe that the expected line there in purple is an overestimate for anything past the first wave of the pandemic. And I'm going to hand over to Peter now. To talk about surveillance of mortality by underlying cause during the pandemic.
Thank you, Shamini. So next slide, yeah. So that what we see is during the pandemic, COVID-19 was coded as the underlying cause of death in many cases where individuals had been tested. What this meant was that other causes of death that would normally occur to people who were vulnerable were suppressed. So we see that dementia, Parkinson's disease, and cancer, there was a slight deficit during the pandemic. However, other causes, which may have been due to lack of treatment, but also to the vulnerability of individuals, still showed an excess. And these may have been individuals who weren't tested, but still had COVID. Next slide. And looking at these individual causes that were on the previous slide, we can see the pattern here, where in the first wave of the pandemic, there was an excess both of underlying cause and COVID cases. But as time went on, for dementia and Alzheimer's, as time went on, we see a deficit. And this is the deficit that was in the previous slide, due to the fact that many people with dementia and Alzheimer's had died prematurely during the first wave of the pandemic. And this is the displacement we talked about, and I'm going to talk a little more about that. Next slide. And we see the same pattern for Parkinson's disease. And next slide, please. And a very similar pattern for cancers, again, where cancer screening and treatment was suspended during the major waves of the pandemic. And therefore, we got excess cases. Go on. Next slide, please. On the other hand, the pattern for ischemic heart disease was very different, because although we saw the same pattern in the first wave, in subsequent waves, we saw continued excesses, both from ischemic heart disease and from COVID-related deaths. Next slide. And the same occurred with cerebrovascular disease. Next slide. And a similar pattern for heart and other circulatory diseases. Next slide, please. So in principle, this is a little diagram of what happens. What is shown in grey are a representation of the normal deaths, and you can see that the seasonal pattern that we get of excess winter deaths in the UK. Next slide, please. And then if we have a disruptive event, we get excess deaths from that disruptive event. And those deaths would have occurred a lot later. Those are the little red squares with white in the middle. And they've occurred earlier, so they will not occur when they would normally have occurred later in time. Next slide, please. And over time, this results in that pattern we saw in those earlier slides of an excess in the first period, with some deaths concealed, the very dark red ones concealed, and then later on you see a deficit in periods where there are no, where there's no pandemic period. And then when you get another disruptive event, you get the same pattern recurring. But in that period, you don't see the same excess you would have done, because many of the deaths had occurred in at the first disruptive event. Next slide, please. And yeah, next slide. So, as I said, the problem with looking at underlying cause is that COVID certification trumped some of the other causes of death. And therefore, what we did in England was to shift to looking at mentioned causes, to identify those cases where people with diseases like cancers and dementia were dying with COVID, and the COVID was on the underlying cause on the death certificate, but these other conditions were mentioned as contributory causes. And when you do that, you see that there are excess numbers of deaths in all the causes I've discussed. And even for heart disease, you see an increase in the excess mentions of heart disease, because people with heart disease are dying of COVID, and that's being put on the death certificate as the underlying cause in many cases. So the mentions provided a better measure of what had been happening during the pandemic. Next slide, please. And on the right-hand side, you can see some risk analyses of which diseases caused the greatest excesses during the COVID pandemic. And on the left-hand side of this slide, a number of the papers that have been written in England about this phenomenon. And once the slides are available, you'll be able to access these papers. Next slide. Over to you, Shamini.
Thanks, Peter. So forecasting beyond any disruptive event, what Peter has described is what we did within the pandemic, looking at underlying causes of death, and then realising that because these have been displaced in time, they were no longer reliable estimates. So our quick fix was to move to mentions, because mention of any cause would be on the death certificate, and then that would lift that up a bit. But what we really do need to do is adjust our estimates of what we expect by underlying cause for this displacement. So we can acknowledge that forecasts beyond the pandemic or any disruptive event, these are obviously, like I said earlier, based on historic trends. Normally you get a catch-up period, but in this case it's been the period of the pandemic's been too long and the disruption's been too big for that. Conventional forecasting methods have become increasingly unreliable. We've come up with 5 main reasons for this. Some of these you'll be very familiar with, but the one around displacement is the one that we've really done quite a lot of work on. The first is that events such as admissions in PHI, for example, would have been displaced. Some will have occurred earlier than expected, perhaps related to IHD, ischemic heart disease. Perhaps this was the reason we've seen excess, and we can't tell that from our mortality estimates, may be related to long-term implications of COVID-19 infection. But it may also have been a result of a reduction in health screening or life-saving treatments. Either way, we have seen that that mortality has been brought forward, and therefore we expect that morbidity to have been brought forward in those conditions. But in many cases, particularly relevant to PHI, admissions will have been displaced to a later date, for example, elective surgeries, and some of these would have been avoided completely. Like I've mentioned, complications of COVID-19 infection may increase morbidity from other causes, resulting in utilisation of additional services over and above what would have been expected. And then finally, extrapolating historic trends over the length of pandemic period is becoming increasingly unreliable, just due to the extent of the time. So while we had a quick fix, which was to move to mentions when we were looking at underlying causes, these models that we use and the estimates of excess by underlying cause, they're used by our clinical directors for responding to the pandemic. So we have to be very clear about when they become unreliable. So we've done that quick fix. But in the meantime, we've been looking at mortality displacement and making an adjustment for that. So the next few slides, I'm going to talk through how we're doing that and give you an example of some of the analysis we've done with the hip fracture data set. So we were tasked with adjusting the expected mortality estimates for England to account for mortality displacement that occurred as a result of the pandemic. And this task came from NHS England because many of the expected deaths or the estimates of expected deaths are used for hospital resource allocation. So we had that task come in at the beginning of 2021, and since then we've developed a Cox regression-based methodology using time-dependent covariates to estimate the profile of enhanced risk of death over time among people who had COVID-19. I'm not going to go into any detail around the methodology in this particular presentation. Now, if anyone wants any detail, we'd be happy to give a different presentation with the methodological detail. But we're also going to put into preprint in the next month or so our methodology paper, so that should be publicly available. So the methodology very quickly involves 4 main steps. The first is to estimate the combined hazard using a Cox proportional hazard model with time-dependent covariates to capture the variation in risk of mortality following a COVID-19 infection. So we fit that model. And then we run simulations in our population of the survival profile of individuals based on their combined hazard and the combined hazard. So that's the baseline hazard plus their relative risk structure. And the first time we do that, we assume the COVID-19 is within the population. So exactly what is within our model. We do that for every individual. So for example, 500 times. And then we rerun those simulations a second time, but this time we set the COVID covariate to 0 and we don't allow them to have COVID. So then we look at their survival profile over the period with and without COVID. We then summarise each individual's median survival time and compare the difference between the survival in the simulation with COVID and survival without COVID. And that results in a displacement of mortality for each individual. And then the final step is to then apply this displacement correction to the expected deaths and therefore the excess deaths for those estimates. We used 2 data sources for this analysis. The first was for the development of the methodology. It was a smaller data set of 100,000 individuals on our hip fracture register in England between February 2019 and October 2020, so just under 100,000. We had about 13% of those testing positive to COVID. And being a hip fracture data set, they're particularly old population relative to the general population and had a lot of mortality events. So they were a great data set for analysis and development of the methodology. Going on from the development, that's the results of the hip fracture data set is what I'm going to present today. We are now working on our national cohort. We have every individual in England, which is, we have it from the vaccination register. It's roughly 62 million individuals. We've linked their hospital episode data throughout their lifetime to their GP data, primary care data, up to case records in England, so we can tell when everyone has got COVID, and many multiple COVID infections, and then their death data to look at who died. And we also link in some geographical data around postcode, because that's one of our main indices of deprivation is by postcode in England. And then we've got demographic information on the individuals. So that one's very comprehensive. The hip fracture data set was very comprehensive in terms of comorbidities as well. But for a national data set, this is it's quite novel that we have access to this. So results from the English hip fracture data. We see a distribution of mortality displacement by age, sex and frailty here. And so if you see up in the top of each box, you see the median. That's the number of days that these people's lives were displaced for that particular group. So for females under 80 in a low frailty within our hip fracture data, we saw a median of 535 days of displacement of life. So that was their death was brought forward. And as you can see with these estimates, displacement is lower, so fewer days of life lost among males compared with females, because males have a lower life expectancy. Among the high frailty, you see fewer days lost compared to the lower, because you would expect them to have a lower life lower life expectancy as well, and fewer days of displacement among the older compared with the younger. So it all looks very sensible. And when we apply that to the national estimates of expected deaths, if we were to apply that displacement, you would see in the top line is the original deaths of what we expected. You can see a substantial decrease in what you would expect in terms of the number of deaths per day following the first wave of the pandemic. I think this is obviously very hypothetical because the hip fracture data set is not a representative of the national sample, the national database of individuals. So we wouldn't apply this, but this is an example of the displacement. And then if we were to then go on and look at our excess mortality estimates, these would be inflated as a result. So we do expect that we do see clear evidence of displacement among this population. And when we apply this to the general population, we're in the process of doing the modelling of that now, we expect the mortality displacement to vary considerably by age and disease groups. We expect a higher level of displacement among the young groups, obviously, who had a higher life expectancy. But we don't expect this to impact our expected deaths as much in the short term, as the older population are obviously having a higher impact on our deaths today. But we do expect a large variation. We do believe that there's been displacement of events such as healthcare utilisation within PHI, but the extent to which it's occurred by type and like the type of utilisation and how much that timing has been displaced needs to be investigated within insurance data. But also ongoing monitoring of outcomes following any major disruptive event is essential to respond to unexpected variation and consequent upon that disruptive event. So effectively what we kind of summarise and say is we are seeing this. We do think it needs to be monitored within PHI data, and the only way to do that is to use your baseline forecast to have a look and then make the adjustments with this sort of methodology going forward. Thank you.
Thank you, Shamini and Peter. As the old English saying go, robbing Paul to give Peter, or the other way around. So it's good to have Peter with us today. So Peter, whenever I am having the privilege to meet you in London, I'll take you out for a cup of tea. There's a couple of questions, and I think clearly the statistical rigor and the work done around this novel approach is something that can be quite useful in a number of applications. From the health context, what we are particularly interested in is to understand if we have through the pandemic not treated people to the same level as we had before, do we have a risk of having claims that emerge later on in the system due to untreated condition that worsen or that change over time? So one of the applications that I thought of for this particular piece of work is to, because we have seen that there's a direct increase in specific clinical or reasons for death later on during the pandemic. And I think that's the part where the level of correlation between mortality and morbidity would be something interesting for us from a PHI perspective to look at. A couple of questions. I think the one that we have also from the audience, Ignatius asked around the cause, if the cause of death, if that is standardized by age, etc. And I do think that on one of your slides you do answer that question by looking at the frailty and age as well. So if you maybe want to take a second to answer that one.
Yeah, thanks. So underlying cause of death in the excess mortality estimates are estimated by age, sex, ethnic group, and also the the geographical area. And we go down to local authorities in England. So yes, the standardised, the model is fit in those ways, and the methodology for that model is published with the estimates on the website, and you can link to that. There's a link to that in the presentation if you want to have a look at that in any detail, as well as the code is there.
Thank you, Shamini. Peter, Shamini, is there maybe an example or two that you can provide in terms of where this type of analysis was used in the pandemic response? And if you can perhaps expand a bit in see what other type of uses you can see in wider areas that one can use that type of information for. And specifically around the methodology that you have developed, because I think that this now specifically applied to this instance, but there may be other applications where the novel approach can be useful for actuaries and their actuarial work.
Should I answer that?
Yeah, go for it.
I think there were two applications of the excess mortality model during the pandemic. The first was at a national level, where it was fed into the decision-making by the Prime Minister and others as to when to lock down and what response to make, because there was an awareness very quickly that with inadequate COVID testing, they weren't getting an accurate picture from just the numbers of people dying with COVID. So our excess death model was used in that sense to inform the actions that the government should take. More in the longer term, what I've found is that we, as Shamini mentioned, we produce these estimates at local authority level. And at local authority level, there is someone called the Director of Public Health, who is responsible for local action. And several directors of public health have been looking at the excess mortality in their areas and seeing where what is happening in their area is differing from what happens nationally. So the national message may be COVID is declining, but particular directors of public health saying that may be the case nationally, but in my area, I've got a large number of deprived individuals or individuals from minority ethnic groups, and they're still showing an excess of mortality, and I need to take action locally. So both nationally and locally, the information was used.
Thanks, Peter. And I think that's what's really useful about what Peter said is it gives you an understanding of the sort of breakdowns. If your forecasting is broken down into the important groups, this is how this can be utilised generally. You can monitor impact of a pandemic, for example, on particular areas of the business, or claims, for example, within private health insurance, and then be able to respond just as we do in public health, looking at interventions for particular groups who are affected. The PHI industry can respond in quite a sophisticated way to the impact of the pandemic by monitoring the areas affected. Now, in terms of displacement, the second methodology, that can be used, we describe it in relation to COVID-19, but really I can see one of the things that I think about often in terms of using counterfactual analysis and responding to it is around contract negotiation and wider impact things that are going to have quite a big impact within the PHI industry, to understand what that impact has been based on what you would have expected, and then do the adjustments on your expected estimates.
Yeah, we will also at the end just come back to you in terms of just guiding us in terms of where we can find more information, because this is it's a quite deep technical and rigorous approach, and I'm sure there will be some people that would be interested to see how can we benefit from that, and understand that this work will be published as well. So once those publications are made, I think we can distribute that as well. Anthony asked a question. Is there any evidence that people with non-COVID related conditions also experienced higher morbidity because they could not get treatment? I think that's the question that I asked, or not asked. I said I think the main question that we would have in this industry, and we appreciate that in Australia we had a far lesser disruption than would have been experienced in other countries. So there is limitations to how you can draw inferences from other areas. But I think the question is that if a person that would otherwise have been not having COVID, was a high mortality, even though they did not have COVID, but simply were not able to access treatment or did not pick up in the system before.
Peter, I think that one you can probably talk around.
Yes, I think as we outlined, an individual with a pre-existing condition could either have been more vulnerable to COVID or have failed to be treated. And at the moment with our excess mortality model, we can see, as I showed with the mentioned data, that you can identify that those individuals have an excess risk during the pandemic. What is difficult within that model to see is who was dying because of lack of treatment and who died because they had COVID, but it wasn't identified and therefore not on their death certificate. So we can't unpick those two in the existing model, but that's where we expect the displacement model to be able to shed more light, particularly in periods when there wasn't much COVID around, or as we've got now with the Omicron variant, which is not particularly fatal. And when we've adjusted the excess mortality and find an excess for other conditions other than COVID, then we must conclude that those individuals are dying because of lack of treatment from their diseases. So that is exactly where we're heading with this displacement model.
I think that's that information coming from that analysis would be super useful in our context. We would have to adjust for the level of disruption that we have had here. But what roughly would be the planning for releasing that kind of information? Because we also have the pandemic is now nearing a point where things are starting to return back to normality. So at some point in the future, we will not necessarily derive a lot of value from knowing that as a past one. So as long as there's something that might happen in the future, it would be good for us to appreciate that. And I think everyone probably in the room is aware that the Department of Health is looking at ways for the funds to show to the public that we have done what we said in terms of not profiting from COVID. And one of the big risks for us is that there will be some exposure still that we are not able to see. So that would be a useful piece for us to take further.
So in terms of timing of the release of that data, I would say it's by the end of the year for us, just because of the size of the data set. I will say that there is some evidence within the published literature from studies that is not national level data. So just being clear, we work on the national level data, not study data. But there have been some studies of smaller populations and sample populations where you might be able to find some estimates there, just not within our national data.
Thanks, Shamini. We also you have used a national data set with lots of health information and things that connect together. I think for any actuary that's interested in the health space, that level of information and data can be quite useful. So can you maybe take us a little bit through what is the difficulty that you had in terms of getting that data through, and is there limitations on how you can use that data? Because we appreciate that if it's publicly owned data, it may not be necessary or use. We don't know if the private sector would be able to access that sort of information. Shamini, we lost your voice there for a moment.
Yeah. No, I can hand it. For many years, there have been very great information governance restrictions on what data you can link. But what happened during the pandemic was that it was realized that there was a public health need for the information to be linked. However, we or colleagues had to apply for each of the data sets that Shamini showed on that slide, for each one to be linked. and we were only allowed to use it for this COVID-related analysis. We didn't have the permission to use it for any other purpose. And parallel to what we were doing, the Office for National Statistics had legislation that allowed them to do similar linkage, but they again only had the permissions to do it in this case for COVID. And I think thinking forward, policymakers have realized the value of being able to do this linkage and to do it in a secure setting. And what is being developed at the moment is thinking about how it might be carried forward for other situations and to improve the safe setting that can be, in which it can be accessed. So that has been a development over the last 2 years that may have happened anyway, but would have happened much more slowly in a much more restricted way. And what is the result of this, the trauma, if you like, of COVID-19 is that it has been accelerated, but at the moment, the uses are still restricted to COVID-19 analyses, but I fully expect that other analyses will be permitted in the future. And it's been a period of since I think it was the early 1980s when restrictions were placed on being able to link data as the power of linkage was realized. So we're going through a cycle where there is more access. And one of the things that is being done in the UK is to look at how researchers can access some of these linked data sets, as I said, in a secure setting. So it may be that arrangements could be made for in a research environment for others like the insurance industry to access the data once those secure settings have been established.
And I think it's worth saying that looking at making sure that we talk to people about what we can do with it, with the mortality displacement, and make sure that those findings are spread and the information is spread about the importance of using these data sets is going to contribute to that agenda of linking data sets and making them more available.
Yeah, the pandemic have accelerated also like the working from home and the ability for us to stand up people, in different environments, which before that there were lots of reasons why it couldn't work until it really needed to work, and then things come together. So if there's a good outcome then from that in more accessible data, that'd be great. I think there'll probably be some time before the private sector can use that for commercial purposes, but I think there's definitely in our industry where you have a lot of fractions in terms of the continuity of care, where different people are looking at different aspects of the healthcare continuum, and that data not speaking to each other is a continuing problem. And I think there's definitely a case to be made for healthcare in general to get that information more generally available. A question that we have, and we'll stop after that one. How much does the baseline model with zero COVID covariate differ from the extrapolated forecast before COVID? So, Shamini, it speaks to your point around the liability. So at what point is the COVID impact or the displacement impact making the baseline irrelevant?
So they're done in slightly different ways, I have to say. One's a quasi-Poisson model. So the models aren't, and they're parameterized in very different ways. In that we don't have comorbidities within the baseline model, because we're looking at it's just looking at historical mortality estimates. Whereas the Cox model is looking at individuals, every individual in the population, alive or dead. So it's a slightly different population, different approach. But how much does it differ beyond the first wave of the pandemic? We don't see that the baseline estimate is reliable from that point onwards, other than being used as a cumulative to assess the cumulative impact of the pandemic. That's where if you use it for that, then it's absolutely fit for purpose, because you would continue there and say, look, this is the overall impact, and it'll all tend to zero eventually because everyone dies eventually, right? But if you're looking at it for surveillance and looking to respond, then you need to make the adjustments. So there's that kind of theoretical approach that differs there, but much beyond the first wave, we don't see it. And our first wave was our biggest wave. It may not be once we adjust our estimates. Maybe that baseline's brought up and we find out the second wave and the third wave were bigger than the first. But at this stage, we see the largest impact in that area in terms of displacement as well. I don't know if, Peter, you have anything to contribute on that?
Thank you, Shamini and Peter. We are running out of time, so I'm going to stop us there. I do, for any questions and for more information on the baseline, please do contact me and I can put you in touch with Shamini and Peter and the team who has done this work for more detailed analysis. Shamini, Peter, thank you for your time. Also, give your thanks to Paul for his involvement and contribution to this outcome. And we'll see you later. Thank you all.